All right, so today on Road to 250, I am gonna talk about some autosomal dominant diseases, those including von Willebrand disease, retinoblastoma, and Marfan syndrome. All right, so to start off with, for von Willebrand disease, there are three types. Types 1 and 2 are autosomal dominant, and type 3 is autosomal recessive. And then the general idea of von Willebrand disease is that it is a von Willebrand factor deficiency. And as we know, von Willebrand factor is required for platelet adhesion. The gene that codes for von Willebrand factor is located on chromosome 12. And overall, the idea is that von Willebrand factor binds to the following to aid in clotting. So that includes factor 8, GP1B, platelets, and collagen, which is going to be exposed from some type of endothelial damage that requires clotting. So here's a picture to kind of show you guys the von Willebrand factor. Here you can think of the collagen disruption or exposure from damage in the endothelium. And then you can see that von Willebrand factor binds to GP1B. Inside the endothelium, there's factor 8, and then platelets. It's going to cause allow for adhesion of platelets, and yeah, those were the 4 factors that I mentioned. And then here in this in the first aid picture, we can see how inside the endothelial cells is where the factor 8 also lies. So symptoms usually pretty simple and easy to catch on to: easy bruising, nosebleeds, heavy menstrual periods, lots of blood loss in childhood. So pretty easy to pick up on. So it is a intrinsic pathway coagulation defect, since it acts to carry or protect factor 8, and factor 8 belongs in that side of the pathway, and hence why we will also see an increase in the PTT time if that is deficient, if von Willebrand's factor is deficient. So in turn, that's going to cause, like we said, the defect in the platelet plug formation, especially platelet to von Willebrand factor adhesion that's needed to initially adhese the clot to the endothelium. So the overall idea in this presentation today is that it is an autosomal dominant disease. It's mild, but it is one of the most commonly inherited bleeding disorders, as it is autosomal dominant. No platelet aggregation can occur with Rhesus-Eaton cofactor assay, which I'm going to discuss in a little bit detail. And then treatment is desmopresent, which releases von Willebrand factors stored in the endothelium, which I'll also touch on a little bit. So again, bleed time is going to be increased as we are unable to really form a platelet plug. And then the PTT time can be anywhere from normal to increased. Okay, so to break down a little bit of the types. So type 1 is a quantitative effect or quantitative defect in the von Willebrand factor. So more so about the number of von Willebrand factors available. Again, type 1 is autosomal dominant. Type 2 is further broken down into 2A and 2B, which are also both autosomal dominant. Type 2A is a qualitative defect, meaning the amount needed to form a platelet plug is sufficient, but there is poor quality of the actual factor. Type 2B is where there's hyperbinding of von Willebrand factor to GP1B. And however, though, what ends up happening is that hyperbinding of the glycoprotein 1B by von Willebrand factor leads to a reduction in available von Willebrand factor, and then hence as well leads to decreased platelets. So that is what's occurring in type 2B. And then in type 3, there's a complete absence of von Willebrand factor. So it's going to be the most severe, and it is autosomal recessive. So diagnosing von Willebrand's disease, you can measure the von Willebrand factor quantity in a von Willebrand factor antigen assay. You can measure the functionality of the factor via a glycoprotein 1b binding assay. So if there's binding occurring, that can give us an idea that that it is at least functional. You can do a collagen binding assay, which would allow us to figure out whether von Willebrand factor is able to adhere to the collagen in the endothelium. And then we can do a Rhistocein cofactor activity assay. So that'll be the next slide. Overall management, like I mentioned earlier, desmopressin is the best. It stimulates the release of von Willebrand factor from the ribopalade bodies of the endothelial cells and increases von Willebrand factor levels. And I know actually Yash has talked about this as well in detail. Okay, so but a little bit more about Rhistocein. Rhistocein formerly was used as an antibiotic, but it would lead to side effects such as thrombocytopenia and platelet agglutination. And so it was taken off the market in terms of, or was no longer used to be prescribed to patients as an antibiotic. However, what researchers did learn is that adding Rhistocein to a sample of blood would allow them to see if there is any clotting. And if clotting does occur, then that would indicate there's plenty of von Willebrand's factor. And actually, Rhistocein only causes platelet agglutination in the presence of von Willebrand's factor. So it would be a great diagnostic test to use for those reasons. Okay, any questions about or anything you wanted to add? I know we have touched on this topic, so. Okay, so the next topic I wanted to talk about is retinoblastoma. So retinoblastoma is a retinal cancer. Specifically, it's a mutation of the RB1 gene that's located on chromosome 13. And as we know, retinoblastoma serves as a protein, especially in the regulation of the G1 to S phase transition in cell replication. And so when it is mutated, we can't stop the transcription factors from proceeding to do cell replication. So the retinoblastoma protein can either be hypophosphorylated, and that would be considered the active form of retinoblastoma. And when it is active, it will stop the cell cycle if damage is detected and not let it proceed into S phase. If the protein is hyperphosphorylated, that will be considered the inactive form, and this will allow the cell to proceed through the G1 to S phase checkpoint. And I will explain in the picture to show why that is. Yes, that'll just make more sense when I show you in the picture. And so ultimately, if we have an abnormally phosphorylated RB protein, which would be the mutated form, it's going to result in inactivation, and it's going to allow cells that have damaged DNA to proceed through the G1 to S phase checkpoint. However, overall, it does have good prognosis, and you'll understand once I get to the screening process for this disease. Okay, so here's a picture, and what I said earlier was that so the red here is the RB protein, and inside you see this green object, which is elongation factor 2. And ultimately that is going to cause or is going to aid in the synthesis, especially from going from G1 to S phase. And what I said was that if the RB protein is hyperphosphorylated, and then it will inactivate the RB protein. However, it's allowing for the elongation factor 2 to go on and proceed and complete signaling and allow the cell cycle to continue on into S phase. And so that becomes a problem if the protein is mutated, and if it is hyperphosphorylated, it's going to just continue going through without stopping for any damages that are in the DNA. Does that make sense?
Yeah.
Okay. So for screening, this is usually done as a part of the well baby screening when you see them for well child visits. For the normal child, well, in general, you're going to look for a red reflex, and the normal response or elicited response you should see is a red or orange reflection from the retina. You also look for corneal light reflex, and you should, if normal, see symmetrical reflection of the beam of light. However, if the child does have or is presenting with retinoblastoma, you're going to see leukocoria, which is when you perform the red reflex test. In turn, you're actually going to see white. There's going to be deteriorating vision, irritation of the eye, glaucoma, strabismus, so a lazy eye, and you can even see in advanced cases enlargement of the eye. Usually, for the most part, this is going to be seen in like the third world countries. So that wraps up retinoblastoma. Any questions about retinoblastoma or anything anybody wants to add? Okay. So the last one I wanted to talk about today is Marfan's. So Marfan's is a mutation of the FB1 gene that's located on chromosome 15. This gene encodes for the protein fibrillin-1 glycoprotein. And fibrillin-1 is a component of the extracellular matrix. And what it also does is it stores TGF-beta, and it keeps it inactive. And what I read was that fibrillin-1 protein is going to directly bind to the latent form of TGF-beta, and so it keeps it from, TGF-beta from then proceeding on to becoming an active immunological component when needed. And then as therefore it's not going to let it do its normal immunological function. So that was just the idea. And so in patients who have Marfan's, there tends to be an elevated TGF-beta lab. So that was just kind of an additional fact there. But in general, fibrillin-1 glycoprotein is a protein essential for normal functioning of the elastic fibers of the body. So all elastic fibers can be interrupted if that fibrillin-1 protein is mutated. So as we know, again, all three diseases we talked about today are autosomal dominant, and it is a defect in connective tissue affecting the skeleton, heart, and eyes. The FBN1 gene mutation is on chromosome 15, and it results in defective fibrillin, and this is a glycoprotein that forms a sheath around elastin. What disease deals with disruption or mutation of elastin?
Is it anti-1 antitrypsin?
Yeah, exactly. As we know, we're quite familiar with in Marfan syndrome, most of the findings are you're gonna have a tall patient with long extremities, pectus carinatum more specifically, but that does not exclude pectus excavatum. They do have hypermobile joints, long tapered fingers and toes known as arachnodactyly. They have cystic medial necrosis of the aorta and aortic incompetence, and dissecting aortic aneurysms is also very high yield, all three. Floppy mitral valve is also seen. They also have subluxation of lenses, typically upward and temporary. And the idea with that is that I'm going to actually go into it in a second, just kind of mention a little more detail. This slide, sorry, is going to be a little bit more repetitive to what I just mentioned as worded in first aid. But again, aortic aneurysm or dilated aorta is commonly found in the cardiovascular system in these patients. They can also have spontaneous pneumothorax as a pulmonary finding. They do get something called dural ectasia, which is weakening of the connective tissue of the dural sac. It's the most common CNS finding in these patients. It's not life-threatening, but it will be painful and lower their overall quality of life. So again, these are all exactly what I've just said earlier. Just a little bit of detail about the lens dislocation. So fibrillin is a component of microfibril, and microfibril is a abundant protein in blood vessels, especially in suspensory ligaments of the lens. Hence why the patient will have this dislocation of their lens, and they get the upward dislocation. So in vignettes, we can commonly see symptoms such as patients who keep falling, or can't or fall going upstairs because they can't look down. And okay, and then just some integration as the last piece is diseases that look like Marfan's. We have the homocystinuria, which is a methionine metabolism issue, and the difference is that their defect is lens dislocation as well, but they have a downward dislocation, so they can't look up instead. Ehlers-Danlos is the lysyl hydroxylase or procollagen peptide deficiency, and these patients have the similarity in that they have hyperelastic or hyperextensible skin and joints. Aneurysms are also seen in these patients. And they also get a basement membrane defect, so they can also have some bleeding and bruising, which can, some of those things can be seen in Marfan's. The congenital contractural arachnodactyly, it's also known as Beals syndrome. They just get the arachnodactyly similarity with the spider-like fingers with bends, so that would just be the differentiating factor there. Stickler syndrome is a patient who will have flat face, a high arch palate, microagnathia, and hyperflexible joints. So those are some similar findings. And then the MEN2B syndrome, that's going to be the marfanoid habitus that's seen with MEN2B. MEN2B diseases that fall under that. And as we know, in MEN2B, we see the mucosal neuromas. You can also see the marfanoid body habitus, medullary thyroid carcinoma, pheochromocytoma. So, so that's all I got. Anybody have any questions or anything they'd like to add?
What is sticklers again?
I'm sorry, I don't have the details of exactly what the defect in the entire disease or syndrome is. But what I did mention in retrospective to Marfan's is that they tend to have symptoms that are flat face, patients with high arch palate, microagnathia, and hyperflexible joints.
Okay. All right, never heard of it. Interesting.
Yeah. Anything else?
Just to add for Stickler syndrome, it affects collagen type 2 and 11, whatever that is, but type 2 is what we would know a little better.
Yeah. Good. Perfect. Thank you.
There's a type 11 cartilage?
There's so many.
There's so many. Yeah, there's actually so many types of collagen, surprisingly.
Oh, man.
Yeah. Luckily, we only have to know the first four. in terms of the exam, it's well high yield. Okay, so I have a couple questions for you guys. And here's the first one. So an external stimulus to a cell increases the activity of several enzymes, including dihydrofolate reductase and DNA polymerase. Which of the following immediately precedes the observed effect? A, P27 protein upregulation. B, retinoblastoma protein phosphorylation. C, caspase enzyme cleavage. D, GDP protein, GDP binding to RAS protein, or E, protein kinase A phosphorylation.
I'll admit I have no idea.
Maybe A, because I think retinoblastoma has to be hypophosphorylated to be active. I could be wrong.
You're right. It does. The active is hypophosphorylated.
No, I know. Just kidding. I take that back. A would cause it to not go.
Yeah, P27 is going to be the cell cycle inhibitor. And it's going to inhibit the cyclin-dependent kinase during G1 phase. So it's telling us that we have increased activity of enzymes such as dihydrofolate reductase and DNA polymerase. What is that suggesting? How do we get to that point? Or what's happening in order for us to see these enzymes in retrospect to the cell cycle? Okay, so the answer is B. And what they're trying to get us to think about in this question is we see it's quite very broad and I guess very minimal information given, but they are telling us that there is an external stimulus and there is increased activity of these enzymes. These enzymes are normal. They do exist in normal functioning of cell replication, but we need to be worried, or the cell cycle itself needs to be signaling or signaled to say, hey, we're having an increased activity of these enzymes, why, and justify whether it's okay or not. Now, so that is the whole idea. So knowing that there's an increased activity, we need to verify what's going on. And the retinoblastoma protein, as we know, controls the quality, and especially, like we said, it controls whether the replication is good to go and proceed into the S phase, from G1 to S phase. So in this case that this external stimulus is having a negative impact and it's actually causing damaged DNA, then it needs to be signaled, or it needs to do its job of detecting what, which of the following immediately precedes the observed effect. So here, and I can read you guys exactly. It's a UR question, so I could have written it all out, but I got late. Okay, so it says an increased activity in the enzymes responsible for DNA synthesis signifies that the cell is in the S phase of the cell cycle. The transition from G1 to S phase is one of the two primary cell cycle checkpoints that ensure quality control of DNA. Cells with damaged DNA are not allowed to enter the S phase. The retinoblastoma protein is a regulator of the G1 to S phase transition. The RB protein is present in one of two forms: active, which is hypophosphorylated, or inactive, which is hyperphosphorylated. The resting cells in the G0 phase contain the active hypophosphorylated RB protein. So when the cell is stimulated by growth factor, activation of cyclin D, cyclin E, and the corresponding cyclin kinases occurs, and the RB protein is hyperphosphorylated, rendering it inactive. And then the hyperphosphorylated RB releases that elongation factor 2 transcription factor, which allows the cell cycle to progress into the S phase. If it is hypophosphorylated, which is active, it's going to bind to the transcription factor, and this complex inhibits the transcription of genes necessary for the transition into the next phase. So overall, the activity of RB protein is to serve as a brake and stop the cells from dividing if they are damaged.
Cool.
Hopefully that made sense. I have a question ID number if you guys needed it to go back to the question in the new world. Okay, here's the next question. A 12-year-old boy has prolonged oral bleeding immediately after a tooth extraction. Despite several interventions, the bleeding persists for hours and stops only after desmopressin DDAVP is administered. The patient has several dental caries due to excessive juice intake and inconsistent oral hygiene. He has no other medical problems and takes no medications. His father and paternal grandmother have also had excessive bleeding after dental procedures. A review of symptoms is positive for mild bruising on his legs. Which of the following is most likely therapeutic mechanism of desmopressin for this patient's condition? A, binding to renal tubular cell receptors. B, increase in endothelial protein release. C, increase in liver protein synthesis. D, inhibition of fibrinolysis. Or E, vascular smooth muscle contraction.
Is it B?
I heard a B. Anyone else?
E.
Okay. Divya?
A.
Okay. All right. So the answer is B. Ignore the bolded. Sorry. The answer is B. So the mechanism of action of desmopressin is that it's going to release von Willebrand factor from the ribopalade bodies of the endothelial cells, and it increases the von Willebrand levels as like that. I can see why you would think A, and okay, yeah. Okay, so with A, DDAVP also acts as a ADH analog by binding to the V2 receptors in their renal tubular cells, but it leads to an increase in aquaporin channels, yes, and increases water reabsorption and decreases urine output. Due to this action, DDAVP can be used in this treatment of central diabetes insipidus, so not for release of actual, well, that's the answer choice, or the reason why they gave for why it would not be A.
It's asking for this patient's condition. What's the
Right.
therapeutic mechanism of desmopressin? Yes, the answer A is also correct.
Correct.
But in this patient's therapeutic mechanism is to increase von Willebrand's factor release. So that's why it's B.
Yes. Does that make sense for you guys?
Yeah.
Okay.
Yep.
Next one. A 34-year-old man developed severe chest and abdominal pain while shopping in the mall. Paramedics arrive and find him in severe distress. Several minutes later, he suffers a cardiac arrest with pulseless electrical activity and cannot be resuscitated. Post-mortem examination reveals an internal hemorrhage as the cause of death. Histochemical evaluation of the patient's tissues reveals a defect affecting a large extracellular glycoprotein. This protein is normally found abundantly in large blood vessels, periosteum, and zona fibers of the lens, and functions to form microfibrils by surrounding elastin. This patient most likely suffered from which of the following conditions? A, Ehlers-Danlos syndrome. B, homocystinuria. C, Marfan syndrome. D, osteogenesis imperfecta. E, polycystic kidney disease. Or F, vitamin C deficiency.
C.
Okay, so yeah, the answer is C. It's telling us extracellular glycoprotein, all the clues, including extracellular glycoprotein, blood vessels, periosteum, zona fibers of the lens, and functions to form microfibrils. So that's pretty much bringing it down there to narrowing it to C or A. And the heart condition that he is presenting with would allow you to think C or lead you to the answer of C. Does that make sense?
Mhm.
Okay. And the last question. Hypophosphorylated retinoblastoma protein is most likely to perform which of the following functions? A, induction of apoptosis. B, prevention of G1 to S phase cell cycle transition. C, activation of receptor tyrosine kinase. D, opposition of p53 activity. Or E, repair of damaged DNA.
B.
Anyone else?
B as well.
Yep, that's right. B. Hypophosphorylated is the active form, so inactive. That's right, inactive. Now I'm confusing myself.
Yeah, hypo being active.
Inactive. Sorry, active. Yes.
And hyper
Yes.
being inactive.
Inactive. Right. Correct. Alrighty. Anyone? Well, that's all my questions that I have for the day.